Good evening, sir.
Good evening, friends. In the beginning, I would like to thank Rani Hospital for having given me this opportunity to speak to you about basic things about what decisions to be taken while referring cases out of your private practice clinic. The essential thing is that knowing when to refer and which specialty to refer to is a very essential part of surgical general practice. Surgery is one branch which you're not exposed to very often in most of your medical
ते
education.
काय काय ना काय पूर्ण डिक्की भरून ठेवली वाटतं काय ना काय
Please mute the other speakers. Please.
काम कर उरलेल्या गोष्टी आहेत ना डायरेक्ट दुकानात चालू
Vikram,
घेऊन
please
बसत
mute your
संध्याकाळी
speaker. Yeah, thank you. So, what is very important is that we should know where.
येतात आणि बाकी पण येतात
Vikram, please mute your. Can we continue? Yeah. So, can you hear me now? Hello. Yeah. So, the theme of today's talk is about precision timing, a general practitioner's guide to surgical referral. Often in surgical practice, I find that a lot of cases are referred quite out of time. We get references in which we have lost the golden time when we should have salvaged tissue, salvaged the organ, or even salvaged the patient. So, hence, timing is a very important factor in this reference. The paradigm shift has occurred from what it used to be. It used to be all of you hand over the case to a surgeon and then that's over. Such is not the case now. There is a strong paradigm shift in which you have to work together with the person you refer to before referral and even after any surgical procedure is done. Because once the patient is discharged, the patient comes back to you and you need to look after the patient as best as you can with guidance from your surgical colleague. Now, there are indicators for early referral. There are certain cases where you have to act immediately. Suppose you have a patient who has an inflammation, abdominal or soft tissue, abdominal in the form of cholecystitis or diverticulitis or any of the inflammatory conditions which are not presented outside, but you have inflammation going on inside the abdomen. Or it may be a biliary colic or even a ureteric colic, a hernia which is obstructed. Sometimes you miss out the hernia because they're in a concealed part like a femoral hernia or a very small neck umbilical hernia which you don't appreciate. Pain is a very important factor in your diagnosis. A patient who complains of pain is in pain unless proved otherwise. Hence, referring early will prevent you from sending a patient who has had a perforation and you have referred the patient when the patient is already in peritonitis and in septic shock. In end-stage chronic inflammation, laparotomy becomes difficult. We often get cases of cholecystitis where in the first bout of cholecystitis, the person has not referred the patient to a surgical colleague of his, and hence you have a case in which it is fully inflamed. You have missed out the period in which you could have gone in and operated laparoscopically early. Mind you, acute cholecystitis is not a contraindication for surgery, provided you get the case within 3 or 4 days of the onset of infection. acute cholecystitis is different from acute appendicitis. Although even in acute appendicitis, going in late becomes more difficult. It was believed earlier that in acute cholecystitis, you wait till the inflammation settles down. Such is not the case now. You can go ahead and operate within the first 5 days. I operate within the first 5 days. If you are finding a patient with good, healthy condition, physically well restored, then you can even operate till the 7th day, but not beyond the 7th day. If a patient comes after 7th day, everything is sealed off inside, and then it is better to wait till all the inflammation and all the process of inflammation settles down over a period of 3 weeks and then go in. On the other hand, a hernia, even if it is an obstructed hernia, if you get the case late, you have to explore because you may have a gangrenous bowel, and therefore this gangrenous bowel can slip back into the abdomen and cause severe consequences. So please refer the case early. Let us not wait and see, which is wrong decision now. What is urgent? Every case is not urgent. If you have a patient whom you suspect could have a upper GI mass, you don't wait for years, but you can wait for a week, check out, do the investigation and send. But there are some cases where you cannot wait, like volvulus. In case of volvulus, you have a condition in which you have the bowel which is twisted around the axis of the vessel supplying the bowel, and that can cause rise to death of the tissue because of ischemia. This is the urgent referral. If you have a sigmoid volvulus or even an intestinal volvulus or even a gastric volvulus, you have to refer as soon as possible. Suspicion is more important than waiting and watching. A ischemic limb. If you have a patient, especially who can have embolism and the artery to the hand or the finger is embolized, get embolus blocking the blood supply, please refer as soon as possible to a vascular surgeon. Don't send it to a surgeon, send it to a vascular surgeon because intervention can be done and they can clear. Nowadays, even intervention radiologists handle it, but they do it along with the help of the vascular surgeon. We often get testicular torsion who come to us after 6 hours. They come at 12 hours, sometimes they come the next day, and they come with a testis which is black. No point in trying to save this testis because they're already dead. Vascularity has gone, tissue has been damaged, and it is impossible to save this testis. I remember a case who came from Vicroly. 6 months before, he had a torsion of the right side, young boy of 18. Once he had a torsion of the right side, the surgeon did a orchiectomy on that side, but mind you, he did not fix the other testes. When he came to me, he had a torsion of the other testes and came to me after 18 hours. When I explored, the testis was gone. So I had to do an orchiectomy on the other side. The boy now comes to us, to my urologist. My son is a urologist, Gaurav, and therefore it is better that he sees it and he gives him supplement of testosterone. But that is not the answer. If the other doctor had fixed the testes earlier on the opposite side, that would have been very helpful. So torsion of the testes, if you suspect, there are ways of clinically finding out torsion of testes and differentiate from orchidopexy, orchitis or epididymoorchitis. But if you suspect, please send immediately to the radiologist. Tell him or her to do a Doppler, arterial Doppler. If it is negative, if the blood supply is good, there is no loss, only one investigation is done. But if you have suspected torsion and if you have sent the patient to the doctor, the radiologist, and if he has or she has diagnosed it, you can immediately refer and clear everything. So early referral is very important when you have testicular pain, sudden onset. That is very important. No clinical picture can often be misleading. In the textbook, you'll read that if you lift the testes, if the pain increases, it is one. If the pain does not increase, it is the other. They will also talk about feeling a knot in the cord, so that means it's a torsion. But often clinically, you cannot make out. So it is better to do a Doppler. Again, in the ischemic limb, pulse is not an indicator of ischemia. You have to do arterial Doppler. Pulse is a very crude method of diagnosing ischemia. Cold temperature, less sensation, more tingling sometimes are all indicators, but Doppler is the best way to find out. Please do arterial Doppler to see ischemic limb. Please do a total Doppler artery of the artery. Please mention arterial scrotal Doppler. At the same time, tell the patient the urgency of this thing. Tell the patient that if you don't do it, or tell his parents or the person accompanying, you can lose the testing. Strangulated hernia is another important thing. If you strangulate, if a hernia is strangulated, it can mean death of the bowel. If in your clinic you try to reduce it, the patient hernia gets reduced, and then you sit tight thinking that, well, I have done a great job reducing it. But remember, there can be reduction en masse, in which case the strangulated part stays like that, but the whole sac goes inside, and the patient presents after a day or two with peritonitis. When you go in, you find that the whole sac had got invaginated, and therefore you have lost another case in which you have to do a bowel dissection. Abdominal sepsis spreads very fast because the peritoneum is a parchment membrane through which all infection can go into the blood vessels. That's the best way for infection to occur. And hence, it is very important that you do not take things for granted. So, volvulus, ischemic limb, testicular torsion, and strangulated hernia are all important things where you have to refer as soon as you see the patient. There are sometimes you might have to go with the patient. If you find that the patient boy comes in, he's a IT professional staying alone, especially in places where there's a lot of paying guests staying, you please accompany the patient or send your compounder with the patient, because it is very important that he doesn't get misled, because these are the people who see IT, and when they see IT, I always show them this small little cup I have, which says, please don't confuse your Google search with my medical degree. So patients often go and try to Google it and see what it is, and then they don't come back and they don't do anything about it. So please accompany the patient, tell him it is required. Sometimes we have cases which you can wait for a short time. Post-operating, if there is a bleeding, please consult the surgeon who has operated. Even if you are not referred, speak to him, find out what has been done, and tell him such a thing has happened. Diabetic osteomyelitis, a diabetic foot patient who has a trophic ulcer below the sole, and is continuously having pain, fever, discharge. Don't take it lightly. My request to all general practitioners is that please examine the web spaces of the foot. That is where the ulcer starts. Tell them not to par their nails on their own. Tell them to do it with a professional. Go for a care, pedicure for the foot or manicure for the finger. Finger you can see, but foot often you cannot see, especially when most of the patients develop a nice pot belly where he cannot see the toes at all. So there, it is better to go to a pedicure, tell him to do it. When you injure the leg, the problem. Another thing I've seen of infection, women who shave their armpits, don't put any antiseptic. And these are the patients who develop ulcer abscesses in the axilla and often neglect it. And then later on, they come with big abscesses which require surgery. Diabetics are, of course, more prone to it. So, in necrotizing fasciitis, often that is a condition which happens in the most of the time in the lower limb. It starts with a small wound. There are compartment in the leg. So the small wound goes and infects inside. There is pressure, and the blood vessels going through that compartment get obstructed. Now, these are the blood vessels which supply the distal part of the foot, and hence you can develop gangrene. In necrotizing fasciitis, besides the specific antibiotic which you have to start, it is also very important that you do a release incision. When you do release incision, the pressure goes away and you prevent compartment syndrome of the lower limb. In oncology, if you have a soft tissue mass, you can wait for some time and then confirm the diagnosis by doing investigations. You can do a CT, you can do a MRCP, whatever is required in the particular case. Remember, in the case of abdomen, in especially biliary system, ERCP is not a diagnostic tool. If you want to see the biliary tree, you do a MRCP, magnetic resonance cholangiopancreatography, wherein you will see the full tree, the biliary tree, the right hepatic duct, left hepatic duct, common hepatic duct, cystic duct joining, common bile duct, and then pancreatic duct at times. So MRCP is a very important investigation where you suspect gallstones. The best investigation for diagnosing gallstones is your sonography. But if you want to confirm, you must do a MRCP. You can take the help of a surgeon asking him for his guidance. CT scan is to be done mainly when you have a complication following surgery, when you expect collections, when you expect other situations. Now, another place where MRI is very useful to a surgeon, besides extremities, is also a fistula in ano. In fistula in ano, you can have a low fistula, you can have a intermediate fistula, or you can have a high fistula. These fistulas are delineated by a good MRI person who can show you the exact how long the fistula goes. Most of the fistula start in the region of the inner glands and in the intersphincteric area. Therefore, you have to go ahead and cure it. Fistula needs surgery. You can also use Ayurvedic thing like Sar Sutra, but that is to be done only by specialists, not by everybody. If you don't act now, you'll if you see a patient standing position, there is gas under diaphragm, please refer to a surgeon telling him that my X-ray shows gas under diaphragm. When you suspect perforation, don't ask for abdomen X-ray. Ask for X-ray abdomen standing position, including the domes of the diaphragm, because it is important to see the dome. See for the gas below the right dome. Left dome, you'll see the fundus of the stomach. So therefore, the right dome has to be seen. And if there is any fluid air pocket in the right dome, 99.9% it is a perforation. Perforation old perforation may present without the peritonitis if it is sealed off. But okay, fine, it is sealed off, surgery may not be required, but take the opinion. Now we do perforations laparoscopically. Laparoscopy, I do cholecystectomy, appendectomy, splenectomy, hernias, bowel surgery, colon surgery, but also perforation. For a DU perforation, which we don't see very often nowadays because of the good drug regime and understanding of the disease process, we can do it laparoscopically, and it is very rewarding because for a small entry, you treat a major problem which can be handled very well post-op. Now, whenever you suspect volvulus, we have to do either a good CT or you can do a X-ray first to diagnose. A colon which is more than 10 centimeters is definitely pathological. 10 centimeters also, diameter is also very large. Recently, we had a lady with 17 centimeter diameter, distension, gaseous distension. I suspected volvulus because of the gas in the colon. But then I sent it to the radiologist to do a CT. He said there is no crossover. That means there is no volvulus. So we got her back. We put in a flatus tube. It deflated. Recently, about 4 days back, I did a rectal biopsy to see whether it is some form of aganglionic segment, because my colonoscopy, which I did, also had shown there is no mass in the causing obstruction. So there can be always a googly which you have to face according to how it comes. It is very important, again, repeating myself, then acute arterial obstruction. There will be pain, there will be pallor, there will be paresthesia. Paresthesia means pain which is there, but it is a very abnormal feeling. There will be paralysis, persistent cold temperature. During COVID, we bought those thermal guns. It is very useful to keep in your clinic. If a patient comes in with diabetic foot, you just take that and show them the temperature here is less, temperature here is high. So distal part of your leg has low temperature. The patient will get very impressed that you have picked up, and you also will find it easier to handle the situation. Pulselessness is not the ultimate. You have to do a Doppler. Pulse going away is the late stage of the disease. So in 6 hours, this is a viable area where you can salvage the limb. Again, the rule of 6. When you have, as I told you, torsion, if you wait beyond 6 hours, you can have a problem in which you lose the testing. So window opportunity is 6 hours. Now, if you get a patient whom you suspect torsion, you can even send someone to accompany the patient to get everything done. Because if your person is with the patient, then the patient doesn't wander about. Not only that, he doesn't have neighbors who give advice. My biggest enemy and my biggest well-wisher are neighbors, because neighbors often refer you more cases. If your patient has got better, then he tells his neighbor that you go to this doctor and he'll look after you well. At the same time, neighbors often give advice in which you have a wrong decision. You tell them Doppler, you say, नहीं Doppler कुछ करने का नहीं, आराम से जाओ, मेरा cousin को भी ऐसा हुआ था और कुछ हुआ नहीं, ठीक हो गया. So please send your compounder, send someone so that they can advise them what is to be done. And he will also remember you. We had one very, very important management institute owner who came to me on a Sunday with chest pain. I sent my RMO in his car to the hospital. He went there. Within 1.5 hours or 2 hours, his stenting was done and it was cleared. So what happened? He could save the cardiac muscle. So please use your help in the clinic to also send the patient in time. There are some areas which you don't see, as I told you, femoral area, below the inguinal ligament, obese patient. Inguinal hernia you can see, but below the inguinal ligament is the femoral canal. So the femoral canal hernias can often not be seen. Then you have hernias in which only a knuckle of the bowel is caught. It's called Richter's hernia, where you have to release it and observe the patient. If you have a patient who you have reduced the hernia, which has been stuck for some time, please keep the patient in the hospital for a day. Observe the patient, see what is wrong. See that there is no peritonitis. C-reactive protein is a very important investigation to make out inflammation. C-reactive protein is a very rarely used test, unfortunately, because that gives us an idea of the activity of the inflammation in the body of the patient. So you have hidden dangers in routine presentation. Immunocompromised patients, minor abscess of cellulitis in a diabetic can go to necrotizing fasciitis. As you all know that during COVID, because of immunosuppression, Lot of small illnesses went into big inflammation. And the people who were immunocompromised were attacked more. Post-op stress, another pest. When I take my post-op round, I always see for any tachycardia. Same thing. If you send a patient for appendectomy, the surgeon has done appendectomy. After 2 days, the patient comes to you with tachycardia and mild pain. Consider tachycardia important. Get a CBC done, do a C-reactive protein. If they are abnormal, send it back to the surgeon because there might be a early sign of sepsis. In cholecystitis, there may be a leak. So don't sit on tachycardia. After tachycardia for some time, then will come the hypotension. We don't want that to come. We want to diagnose before the hypotension has occurred. A non-healing toe cut or a small ulcer can in the foot can lead to osteomyelitis. If you have a patient with a non-healing ulcer on the foot, get an X-ray done because X-ray will give you idea of osteomyelitis. Early osteomyelitis can also be picked up by doing an MRI. So when you do MRI, you come to know the soft tissue status. So these are important things. Immunocompromised patients, also on patients who are on immunocompromised immunosuppressants like your renal transplant patients, like patients who have got HIV or some form of immunodeficiency. Please get their checkup done to rule out any abscess. If there's a patient who comes to me with cholecystitis or gallstones, and if he has got diabetes, my advice is get operated early. Don't wait for the infection to take place. Most of the time, when we have a patient of cholecystitis, they come and patient has diabetes, the addition inside is horrible. So gallstones in a patient of diabetes, my advice is get operated early because you can have infection which may lurk and you may miss out the whole inflammatory process. Surgical oncology unit. If you have a mass greater than 2 centimeters deep to the fascia, treat it as a high risk and refer immediately. Size often is not an indicator. We have had patients who has had a small nodule in the back and it turned out to be squamous cell carcinoma. I know of a case in which I had done a lipoma excision and I had sent the tissue for biopsy. I send all tissues excised. I would say 99% tissues excised for histopathology. We have picked up appendectomy done laparoscopically, sent for histopathology. It turned out to be adenocarcinoma of the appendix. Send them to they wanted to go to Lilavati, the oncosurgeon there, did an open exploration. He did a hemicolectomy and the patient is still alive and kicking. Any tissue you remove, please send for histopath because surprises can come anywhere. We had a patient who had a swelling in the neck. She stayed in Chembur and we did a excision and it turned out to be secondaries from a thyroid papillary tumor. So it is curable. So we did a surgery for the thyroid and she's still okay. She takes L-troxin regularly because in thyroid, you have to keep your TSH levels in control so that you do not have recurrence. Now, PPIs for a long time. We get patients who have got PPIs going on for a long time. I take PAN every night. I tell them go and get a sonography done. It turns out that the person has got gallstones. So it was the cholecystitis mild grade which was causing the problem and they were treating it as gastritis. And therefore, sonography as a basic rule for all upper abdominal pain is not a crime. It is important to do it. 2 investigations. One is sonography and one is if you want to do, I do a gastroscopy. I don't do gastroscopy in every patient with upper abdominal pain, because if you have a hammer, everything doesn't become a nail. There are some times when you say this is not required. But if there's a family history of CA stomach is a very important thing. Napoleon Bonaparte, the French dictator, had CA stomach. His sister had CA stomach. His father had CA stomach. So this is a familial thing. There are diseases which are familial. If you have a patient in gynec, for example, who has got cervical carcinoma or ovarian carcinoma, you have to do tests. You have to do a BRCA on the relatives, female relatives, because there might be chances of malignancy. See a breast, another disease which can be hereditary. So these are things we should be realizing. Preventive oncology is a very important branch of surgery. Now, when you have a patient who comes with sore throat regularly and has got weight loss, which is more than 5%, you think of reflux, but you do a scopy. You also see the larynx, because you can have a laryngeal lesion which presents as just sore throat. So you have to check to see how things are. Hiatus hernia could be the cause of continuous problem. He goes from doctor to doctor, treats the sore throat, but actually it is the hiatus hernia which can be controlled with drugs and also laparoscopic surgery. We do a laparoscopic hiatus hernia surgery to prevent any reflux, but only after doing a manometry, esophageal manometry, which is very important to do. I sent my patients to my friend in Jaslok, and the reason is most of the centers here charge much more. If a patient goes there to any of the regular centers who are doing about 15 to 20 esophageal manometry every morning, when he takes a Uber, goes to the center in South Bombay or North Bombay, does the test and comes back. It is cheaper. So you have a motility of the esophagus. A esophagus with no motility or very poor motility with hiatus can be a contraindication for surgery of hiatus hernia. Nausea, vomiting are important. Nausea can often mean sudden drop in BP. Abdominal pain. If a patient comes with upper abdominal pain and the ECG shows changes, it is often the inferior wall of the stomach, of the heart, which is the disease part, not the stomach. So these are places where to be careful where to refer to. Jaundice. I had a patient from jaundice who had a bilirubin of 30. She had fulminant hepatitis and she improved without anything. I had a 14-year-old boy who came to us who was a juvenile diabetic, and he had very high bilirubin. The first day it was 3, next day it was 7, third day it was 12. Now in sudden spurts like that, and his B and C were negative. So it was hepatitis B A, which is fulminant. I send him, after a lot of resistance, I told him to go to the place where they do liver transplant, where the good hepatologist. He refused. He went to another center. But next morning, he was shifted to the center which I had suggested. He needed a liver transplant with hepatitis A. The progression of the rise of bilirubin was important. And I referred him on the 4th day. So he could undergo a liver transplant. His mother was the donor, and he has survived. Often, you will not get any kudos from this patient, because for them, well, it was unnecessary that I had to spend so much money. But saving that life was very important. When you refer, don't only refer the case. Be helpful by telling the name, age, suspected condition, what is the diagnosis, background, history, examination, vital signs, SBAA for assessment. Give your assessment. I have a family general practitioner in Chembur who's excellent in his clinical diagnosis. So he sent me a case about 6 years back. patient has been seen by 2 gastroenterologists. They say it is normal, but I feel the patient has got ulcerative colitis from the history. Kindly do a colonoscopy. I did a colonoscopy, and there it was. It was a ulcerative colitis. Again, a treatment which can be given and treated. Patients often take medicines for piles. Many of the Ayurvedic medicines contain heavy metal. They give rise to hemolysis. They have blood and stools. They go to a surgeon. So any surgeon does a hemorrhage without doing a colonoscopy. And this is where they missed ulcerative colitis. After a few weeks, when they get better but bleeding continues, come to me, I do a colonoscopy, or a surgeon would have also done a colonoscopy, and there it is. I had a relative in the family who was in another city, and he underwent a hemorrhectomy. He was 70. I just told him, kindly get your colonoscopy done first. So luckily, he went to the surgeon and said, before you operate, kindly do my colonoscopy. There was a mass in the rectum. So high rectal mass can be there along with piles. So piles doesn't mean the disease. It also means the result of the disease which is higher up. So you have to ask the doctor when you refer, I want to send this patient, should he come for your consulting or should he come come in the emergency? So you have to also talk to the doctor before referring. So talking to the doctor, referring the patient in time, referring with the proper guidance is important. Recently, I saw a person who had a brain stroke. So our neurologist, I asked him, what should I do first? Should I do a investigation before sending? I would have done a CT, but he said no. Do a MRI angio. The angio was done, and then he was brought to the hospital. So the diagnosis of middle cerebral artery obstruction was confirmed before came in. Now, this is an important thing. When we talk about SNDT, we think of this women's university. I was in Xavier's in my interscience in 1970-72. I joined medical college in 1970, the Grand Medical College. So SNDT was girls' thing, but SNDT is also important for doctors, not only for finding their spouse, but also for sign, name, date, and time. When you refer, kindly write your sign, write the name below. Note the date and the time. Even in your record keeping, if you are giving the record to the patient, please mention the time and date. It will often get you out of difficult situation. Because date is important, but time is also important. Your signature is important, but the writing your name below it is also important. So, objective is the baseline current kidney condition. Tell them what are the findings. You're the family doctor. You're the general practitioner. You should know about the patient. If you don't know, spend time in finding out what the patient is. The good thing about our country is there is a trend of family physicians still there, although it is fast disappearing. People go to a doctor and expect the doctor should know about the family, because many times the patient says, I go to this doctor because he knows my every vein, because he has known the family for a long time. He knows that your uncle died of cancer of the larynx. Your other uncle also died of cancer larynx. Someone had breast cancer. He'll know all the details, so you don't have to worry about that. So it is very important. The past history of the patient and the family is important. You know the allergies. You know regional disease. There are certain diseases which are more common. If I get a patient from endogangetic plain, Banaras, Bihar, UP with gallstones, I always go in for surgery earlier, because these are the patients where CA gallbladder is very important and very common compared to the other part. If I find a patient from South India, I find that you should treat the stomach. If a patient of abdominal pain comes to me from Tamil Nadu, I will do a gastroscopy, because CA stomach is more common in that area. If I have a Parsi patient with a breast lump, I will check out for CA breast. For CA breast, you don't have to do a biopsy. We have true cut needle. We just do a local anesthesia. We take a piece. You can take a sliver of tissue and send it for checking. Now, all these you have to be knowing, because that is how you can help the patient. Attending CME is very important because that is where we learn about what is going on in the newer world. There's so many things which have changed. So many new progressions have happened, and therefore it is very important to know them. Now, this part we are not doing in our country. We are not starting the treatment. But in case of burns, if you see a burns patient at home, please take a IV, start ringer lactate while shifting, because transport to the nearest center, whether it is Masina or whether it is the burn center in Airoli, you will spend 3 hours. So if you give fluids during the 3 hours, talk to the surgeon, the plastic surgeon or the burn surgeon, and clear that. It is important to give the fluid so you don't lose 3 hours of no fluid. So start the IV. Inform the police if you are suspecting any foul play. You as a family physician can inform. It is not necessary that you have to leave it to the consultant. Again, coming back to the first slide, that there's a paradigm shift. You have to work in conjunction, not hand over the case. There are certain situations where you have to be very careful. Young girl with burns, family dispute burns, industrial burns, all these have to be reported. Now, there is this basic thing of ABCD of resuscitation. Now it is called an ACBD. Now you get the first slide here. You see there is a laryngeal mask. When you put the laryngeal mask, you can do it in the clinic. But if you're not okay with it, you can also call in someone to put in this mask so that you don't have to intubate. You can just put a cuff. Better still, it can be done in the nearest first aid center. Take an IV in burns, try to give oxygenation, defibrillation not possible. But I feel it is time that India also has this rule that there should be a AED, artificial external defibrillator, because when you connect the ports, it will tell you what is to be done, whether you have to shock this patient or not. It is a automatic external defibrillator, which is very helpful. Taking an IV in burns is justified. No one will ask you why you did it. So these are important things which you should follow. A consult does not always mean an operation, but it means shared responsibility. In today's world, please share responsibility. It also helps you learn something new. It also helps you protecting yourself against any medical legal case. I personally would rather see a patient in my office for a maybe than in the OT at 3 a.m. for a too late, like in torsion. So torsion is one case wherein I operate in the night. Appendix I can sit on, but torsion I will like to wait. So I like to take up early. In the case of a torsion, early intervention, so I'll operate at night. Appendix I can operate early morning or in the mid afternoon. As a family physician, you all are not just general practitioner. You are the general who needs to look after the whole community. If every community looks after their flock, we will have a better future. And therefore, consider yourself as a true general. This, incidentally, is Mr. General Dwivedi, who is our Army Chief of Staff. So, all the best to all of you. Kindly ask questions. I'll request our moderator to please help in this question answer session. Thank you.
Thank you, doctor. Dear all doctors, we request you if there is any query or question, you can unmute yourself and put your query.
If no questions, it only means two things. Either everyone was sleeping or I was very clear.
Sir, on behalf of Rani Hospital, I take this opportunity to thank you and taking us to a wonderful journey where we can take a decision on surgical cases and when to refer, to whom to refer. Sir. Thank you so much, sir, once again on behalf of Rani Hospital.
Thank you, Abhay. I just want to add that I always thank Sandeep. Sandeep, I started in 83. I think Sandeep started around the same time. And he always had a dream that time he had only a consulting room on the ground floor. There are a lot of tenants higher up, and how beautifully he has converted his hospital into a ideal cardiac care. They are doing transplants and they're doing uh, uh, not transplant, sorry, they're doing bypasses, they're doing stenting, and so many activities are going on. And it is excellent to have someone so nearby. Their ambulance is also around the corner. They come and pick up the patient whenever required. And it's a quiet area. So Rani Hospital is excellent for patients to recover. And what is amazing, I always find is there most of the schemes which helps even people of the poorer socioeconomic group to be looked after very well. Thank you, Sandeep, and thank you, Abhay, for all the help.
Thank you very much, sir.
Thank you so much, sir. So we'll close the session here, sir.
Okay, bye.
Thanks and have a wonderful day. Sir.
Thank you so much. Thank you.